Good morning everyone, I'm Kim Pointer. We're here today to talk to you about behaviour change and also quality improvement in the bowel screening space. My background has been in nursing, so I've been in the GP land for the last 20 years and prior to that was in intensive care. So seeing definitely what it's like when people get chronically unwell and then also what it's like down the ground at the coalface. So I can understand absolutely what it's like working in your space. I'm also working on a lot of projects across Australia in quality improvement, hospital avoidance strategies and lifestyle strategies as well. So training people in this methodology that I'm going to train you guys over the next 3 sessions and also then mentoring them to embed that into their general practices. So that's who I am and I'm from Medicoach. So lovely to meet you all and I'm going to come back on at about 11 o'clock.
So we're up to the patient engagement piece and also about the team. So Rivka touched on the team and the components of the team. One thing that I was writing and doodling over in the sidelines is about Basecamp. And Basecamp is a wonderful platform to do a lot of networking. And a lot of the projects that I work on, they actually have Basecamp. So if, for instance, one of you have a really great resource, you can upload that document and all the other practices that LinkedIn can see and use that. They can download it directly. There's also a thing called Campfire, so you can ask a question. What is everyone else doing in terms of messaging to get their clients to come in? Or, you know, I spoke to a client face-to-face the other day and used these sorts of words and it seemed to work and we attracted more people. That's the kind of information you can put in there. It's just a fantastic place to chat. So myself, I go and upload stuff all the time when I see really great resources or reference material and then you all can see it. So really keep your eye out on that as well. Alrighty, so let's kick off. We're going to talk about the team approach and as Rivka touched on before, it's about making sure it's not just one person that's all enthusiastic and that's most of the time me in my place. I'm usually like, yeah, let's do. And it's about having other people come on. People's usual barrier to it is, I haven't got time. I've already got too much to do. I'm already, overloaded. So how do we get people enthusiastic? You know, we might be enthusiastic about it, but how do we get others? And this is what I really want to impress upon you today is how do we get the messaging right so that other people can see where it is that we're going and why we want to do this for them as a team. But some key words that I use is efficiency, streamlining processing, making your work life easier. Now, if you're saying those words and people are nodding, they go, yeah, I'd like some of that, then you've already opened the door for them to listen to what it is that you're going to say. My next point in terms of messaging is make sure what you're going to say is short and succinct. So practice it, practice it, practice it, and practice it so that you've got it down a pat. So my role is as a coach. So when I need to explain to reception, how to explain it to consumers that are ringing in, our clients, same with the GP team, same with the other nursing staff when they're doing chronic disease management. They need to have a little snippet of information that's a nugget that they can pass over to the client so they get their attention. It can't be too wordy, it can't be too jargony, it just needs to talk to them about why they would want that. Okay, so make sure you work on what that looks like so that clear and consistent messaging is going all across your team members. So no matter who the client's speaking to, it's the same message. Yes, clear, concise, consistent, but succinct, really important. So we're going to look at what skills are involved. How do we make sure people are working to their top of scope of practice is probably the most crucial thing because the last thing we want to do when we're doing quality improvement is putting ourselves at risk. So making sure we've got the right people in the right roles and how do we optimise that. Probably my biggest piece is the engaging your patient. How do we actually get them from going, yes, I know that's a good thing to do. I've got a toolkit, I've had all the literacy around it. How do we get them from going from that to actually putting it into practice, actually going home and performing the kit or going home and actually doing something? So that was one of my questions that I wanted to pose when I was doing chronic disease management. Clients would say to me, yes, I know, but didn't mean that they went and did or performed those activities. So how do we actually understand someone's readiness to implement change and what's progress for them? So it's not the same. How do we get them to put that? So you can think in terms of your own team with these same strategies as what we'd put in practice for our clients. So the team, we've got a big team sitting around us, and this is adapted from the Healthcare Home Trial. So not only do we have our little team that sits within our four walls in our general practice, but we have a broader team that sits around us. And clients need many touch points and many support structures to house around them. So when we're communicating, collaborating with these other team members, the same thing, we need to have clear communication with them, don't we? That's putting the patient's voice in what it is that they want for themselves. Their optimal version of health and wellbeing needs to be clearly worded and shared across the team. Because one thing that I noticed, particularly in chronic disease management, I'd set some beautiful goals with a client, and then they'd go and see others, and they'd get more and more and more goals, and what they ended up doing was getting overwhelmed and ended up doing nothing. And they felt like they had to come back and make a heap of excuses why nothing happened. Because I went to this appointment and that appointment, and then I ended up doing this, and then I ended up doing that. So small is best. So we've got the hospitals. Can we make sure that we know what programs the hospitals offer and what support structures they can provide to us as a team? Obviously the PHNs are an invaluable resource, just even having things like base camp and workshop days, etc. Insurers are coming more and more into the fore, aren't they? They want to save money in people going into hospitals, so they're putting on a lot of programs as well. And as I said, the allied health providers, community agencies, what is it that they are offering out there? So you may find a lot of resources. Again, those are the things, if you know of something that's happening in your community that others can use, pop it into Basecamp, because it's just gold. Patients usually are the best resource for this, aren't they? Guy came in and saw me and told me about a fantastic community initiative that men who'd lost their wives had started a cooking group, and they'd done it at the community centre, and they'd take $15 each, and they'd go and have a coffee and do all their shopping, come back and cook, and then divvy up the shopping. Now that's gold, is it not? That's the kind of stuff that if you can keep your clients really informed about it, it's just imperative. In terms of scope of practice, who can do what? What are you skilled in? Where does your licence, what does AHPRA allow you to do? So this is from APNA's position statement. So set by legislation, and it looks at what is it that they can do, full scope of their professional licence, and what else have they updated themselves and got certification in. So they might have gone off and done spirometry, or they might have gone off and done some particular other skill set that they've now got a certification and endorsement for. So when we're looking at a proactive team, what do we mean? It means that from the patient coming in through the door, right through the whole way, we're all very clear on what it is that we're going to do, so there's no that duplication. And we see it often in chronic disease management when people go, well, I don't know, are we doing the same thing? We can actually do quite different things, can't we? So practice manager, that leadership and facilitating team communication. So obviously streamlining those meetings and working on those PDSA activities is fantastic. Looking at planning and budgeting, and looking at data cleansing activities and what are we going to be putting as a prompt on top bar, etc., to make sure that the clinicians, when they've got someone either in the treatment room or a care planning session, or the GP has them in there, top bar might be prompting them to grab that person while they've got them sitting there as an opportunistic talking point. The reception, streamlining acute versus chronic appointments. You know, there's one thing that I see quite often is doctors have got a big wait list, so their patients can't access them. And yet we've got nurses who are very capable of doing chronic disease stuff that could be seeing those patients. So streamlining your appointments and getting the receptionist to look at when is their usual GP in attendance and matching that up. Messaging for patient buy-in. How are we going to get these patients, even though they're going to get a kit, how are we going to get them to do the test and see that it's a need? One of the take-home tips that I have for you is quality of life messages work really well. Not that it's good for your health, that's 50% of human behaviour. The other 50% is what am I personally going to gain if I do this? So think about that. put your quality of life pieces in there. So if that's having a conversation with lots of different clients in your organisation and say, what would you do this for? And putting that into a nice little succinct statement that you use, fantastic, do it. Consistent and clear, as I said, patients got to see the value in it, which is again that quality of life piece, isn't it? Why would I put time, energy and effort into it? And it's a little bit of a, tricky situation to have in that we want to normalise, isn't it? Which the girls no doubt will address this afternoon. And we also need to make sure that we're really having that non-judgmental approach when we've got them there. And we put some posters and brochures in the treatment room and hand them out. The nurses, so we know that we're seeing patients, they're coming in. By opportunistic conversations, we can grab patients in the treatment room, can't we? We see them, they're there, let's grab them. So we've got to have trust and rapport with a client. It's essential, isn't it? So what we know when we're talking about adherence, that trust and rapport is the essential element. So if there's a source of connection with, you've seen that patient, work with them before and they trust you. Luckily, nurses are one of the most trusted professionals. The community members see that and they also know or perceive that they have a lot of time to spend with them, which is a fantastic thing. So a non-judgmental approach, listening to what that client's concerns are. You might hear some fear coming through. My grandma or my mum had this. Yes, what if I do the test and I see a positive result? What then? Yes, would I prefer not to know? Is that what the barrier is to undertaking a test? In chronic disease management, it is just the most beautiful fit, isn't it, to do screening and detection activities. So part of your care planning, when you're looking at someone, are they at risk? It's a matter of having a prompt and a nudge there for no matter who is sitting in front of that client, that those questions are asked. All right? Can you put in a shortcut into your software system that is a reminder? So if you look at the RACGP clinical guidelines, you will see that they talk about prevention activities, and we've got those in as autofills for best practice or shortcuts for medical director, that if you're seeing someone, just have a little prompt there to ask the question. Assessing, are they at risk? Have they got that family history? And then the comprehensive documentation of SNAPs, which is smoking, nutrition, alcohol, physical activity. I also add stress and sleep because people's vulnerabilities sit there. Communication is not just within our own team, communicating to our GP post having a client in having care planning sessions, but it's also to the allied team, isn't it? The service providers, also the specialists, etc. And it's usually best if it's two-way. And this is where we bring in the reception team again to assist us and make sure that we're getting two-way communication back. Advocacy. So it's being that voice when you have heard a client say, look, I'm really worried, my mum had bowel cancer and I'm concerned that if I do this test, maybe I'm going to find something out that I didn't want to know. Advocating that to the GP so everyone's aware of that, rather than that patient having to go and tell the same story again and again. Having a working list of following up on non-attendees is a really nice way to say, look, we sent a letter out, that didn't work. So I've spoken to that client face to face and that didn't work, or I've booked them in to come in and they haven't shown up. Who and what way are we going to follow up with that person? It's really nice to have a working list that's transparent across the team on your shared drive so that those awkward conversations are being addressed in a really sensitive manner, so that the patient's not getting asked repetitively and invited repetitively just from a churn and burn activity of lots of letters going out from your reminder recall system. And of course, the wonderful, my favourite of all, goal setting with clients. How do we goal set so that clients go, I really want to do that, rather than going, I'm just going to tell you what it is that you want to hear so that I can get out of here because I've got better things to do on these outside walls rather than in here. Yes? People are getting appeased, people pleasing. That's not the truth that sits behind it. So how do we get the truth out of them? GP, so we've got the crucial relationship, isn't it? It's that team executor of that patient's care, and obviously that empathetic trust and rapport, communication skills, collaboration sitting there as well. Seizing opportunities to broaden the team. Does the GP need to do everything? Or are there other team players who could be really effective here and they could delegate some of their workload off to? So really, with the patient assistance in empowerment and activation, what we looked at in our team is the doctors were going, we've got so much in terms of, you know, our congestion with our books, etc. And we've got all these complex clients who are only coming in once a year for their care planning activities. We know that we need to see them more because the patient outcomes happen in reviews, but how can we fit them in? So this is where we delegated up the roles a little bit. So we had care planning nurses who were then delegating to the health coaching. Complex clients having health coaching appointments so that they could spend due time with them and work on goal setting and accountability with a client. That's a really nice way of starting to delegate and broaden the team up. The GP does the diagnostics, obviously, the referrals, and of course, telehealth is just such an invaluable asset now, isn't it? Just the fact patients don't have to drive an hour and a half down the road to Melbourne and then sit in the wait room for another hour and a half for a 2-minute appointment, then get back in the car and drive another hour and a half back down the road. The collaborative team, as I said, it's really nice to have the same goals extrapolated and that patient's voice so that every team member, when they're chatting to that person and meet that person, are talking on the same topic. See that you wanted to increase your fruit and veggie intake, or you wanted to increase your exercise, those lifestyle discussions. Yes? Those are the things that we want to make sure that we're putting in our notes and our referral letters out. The patients have got to be really clear on it as well. And that's one thing that we often see, isn't it? Patients not understanding why they came today. It's really important that we talk at the same level as where they're at. Specialist lens, particularly if we're going off to ophthalmologists, exercise physiologists, all that sort of thing. Communicating back to the care team and following up. Particularly the TCA agreement, we know that we've got to have that team care arrangement, so that's a really great opportunity, isn't it, to hear what happened to that appointment when they went off and saw the specialist. What was the result? And consider case conferencing for complex clients. Just as a show of hands, how many people do case conferencing in their organisation? Great. Sort of. And what's been, you know, you're just starting now, so it's
someone like multidisciplinary case.
Okay.
Yeah.
And has it been helpful, useful?
I thought it was quite good. It was just between me as a nurse and an exercise physiologist and the general practitioner.
Yes.
And just went through a list of patients and looked if they were due for things and all of that, and then they were fed back the information
Great.
Next time they saw their regular GP.
Great. And what about for you? Do you do it very regularly?
So we case conference probably daily.
Yeah, good.
We have complex clients, but we also have, because we're such a big organisation with family violence and services, kinship care, so there's a lot of clients that are under case conferencing.
Excellent.
Which may or may not sometimes include the CEO. So.
Yeah, brilliant. And we have the same thing. So we have our reception team. I would, in chronic disease management or in my coaching role, print out a template and hand that to the reception team. The reception team would look when everyone's available, send us all a calendar invite, and then we'd all meet at that particular time. They'd coordinate all that and write who was in attendance, you know, in terms of meeting the requirements for Medicare. What was discussed, the patient can be invited, but they don't actually necessarily have to be in attendance. And then obviously what's going to be the outcome. And what we've found when we've used them is that's the best way to actually get some really good, clear pathway forward for a client, because otherwise it's just little doses of this and that, and you're trying to wrap your head around a very complex situation, particularly the social impacts. So we had hoarding, family violence, as well as, gambling issues. And this lady was trying to actually have her doctor write a letter to say that she couldn't work because, of course, Centrelink was making her go and work in an op shop, which, when she's got a hoarding issue, is not fabulous. So the part of her hoarding group was that she actually had to take out 10 items and she was bringing 20 new ones in. So this is where that case conferencing is absolutely gold. And we also heard one of the counsellors had said that she made her first friend after 30 years of living in Australia, and that lady had confided in her friend, her new friend, that they didn't even have running water in the house. Now, this is the stuff that we had never heard about, so it's invaluable what comes out. So thinking about that as well. Community agencies, this is what we're talking about with the social supports, isn't it, and having them involved, home help, ACAT. Support groups and activities, like I spoke about, the men's activities. Psychosocial impacts a person's ability to self-manage, so financial constraints, transport issues, accessing supports, all of those sorts of things. Mental health and addictions, of course. PHN, we've got the resources, supports with education workshops, and obviously you guys are sitting here from a nice little piece around QI and innovation. So the patient, where does the patient come into it? They are critical to all of this working. We might have all the best intentions and all the resources at our fingertips and all the literacy, but they're the ones that actually need to action this, yes? So what's their agenda? What are they going to get if they actually follow this up? So what's their perception of their quality of life? So we're going to work around how do we ask those questions, because if I bet my bottom dollar, if I asked all of you what your quality of life statement is, you'd sort of look at me going, what? What does that even mean? Yes? We're not really clear on that often, so we need styles of questioning to get that information out of them. Are we creating value for them when they show up and spend time with us? Because if we want them to come back and follow up with us and have their reviews and access us when the wheels fall up, we've got to make sure that we're delivering on their agenda, or else they just go, I come, you fill out forms, I leave, why would I go? There's got to be a good value there. And does that person have a connection with their team or members of their team? So I think you would all agree that sometimes a particular patient has a particular connection with one staff member, so it's about identifying that as well. I want you to have a little bit of an opportunity just to stop me talking and you guys having a little bit of putting your heads together, and I don't want you just to sit next to the person that you work with. I want you to diversify your experience and find a new friend that you haven't sat with before, and I just want you to work in teams of two, and we're just going to discuss how do you assess currently in your workplace patient engagement. What words would you use to describe an engaged patient? What do they look like? What do they act like? How do you know they're engaged? And what might their body language demonstrate when you've got them sitting in front of you? So I want you to just pick up your piece of pen and paper, go and find a new friend, and just 10 minutes, we're just going to have a little bit of a powwow and come back together. So what did we come up with in terms of what an engaged patient, or how do we assess for it? How do we know that someone's engaged or they're not engaged? How do we know? What do we call an engaged person?
Someone who's interested.
Okay, in what?
Talking about their health or why they're there.
Uh-huh. So if they're coming in for chronic disease management and they're actually showing up for appointments, yeah. That's a big one, isn't it? I've called you and yeah, I'm not returning that call, not necessarily seeing the value in coming or maybe having that appointment. What else?
We had, no, why are they there?
They understand the intention of what the appointment's about. And we see this often time and time again, don't we, with care planning activities and health assessments. You know, all of that stuff, they go, I just was there the other day and had that done, or I think I've already had this done this year. So there's a lack of understanding on what we're trying to achieve. So the patients aren't necessarily understanding our intent. We might be clear on it, but that's not translating down the line. So if we can marry up some of our activities so they can see it as all one big holistic care activity rather than a little bit of this and a little bit of that I don't really understand, but you make me keep coming back in. Because I tell you what, when I get older, please don't ring me up and tell me to come in. I want to be out there doing good stuff, not in a hospital situation. So what can we streamline and make sure that we're really honouring a person's time is really invaluable? Yeah. What about you? Patient engaged. Anything else?
Their body language.
What does that look like?
Probably happy, making eye contact,
Yes.
opened,
Yes.
crossing their arms even.
Perfect. So the reason why we want to really be drilled down into what their body language is and really focusing in is because when someone is demonstrating that they're not necessarily in the right space and that they want to be there, it can really inhibit our opportunities to discuss health literacy with them. And that's what's the most crucial part of this. So when they're there, and what do they look like, is it the right day to even talk about this stuff? Because they've got a lot of other stuff going on behind the scenes. We might have kids, we might have other pressures with older parents getting unwell, all that kind of stuff. I might have another appointment that I'm rushing to. All of those kind of things can impact that opportunity that you have to grab my attention and impart information. So you having those assessment skills on you is really critical to when is the right time to engage them in these discussions. When a person is demonstrating that anxiety, or I don't really want to be here, it inhibits their ability, their brain activity to think, listen, learn, problem solve and strategize. Now think about that. When we're having discussions with them about literacy or goal setting, it's crucial that they have those elements in there, isn't it? So it might be you framing the question, is this the right time for this discussion? And if not, asking permission to explore it at another time, okay? Rather than just going and railroading them with the information. Because what you'll see is patients then will become more resistive. And that's the last thing we want to do. In primary care, we want to make sure they're accessing those opportunities to explore ideas with us. We don't want to be creating disengagement and resistance. We might have an agenda, and our agenda may be to give, as our duty of care, lots of good, helpful information to our clients when they're there. But we need to do that with permission, and we need to do that with assessment on timing. That makes sense? All right. What was the other question? What words would you use to describe an engaged patient? What words? Questioning. They might even ring up and say, hey, I know that I'm due for. Yes, inquiring, questioning, asking questions while they're in a consult. That's great, isn't it? What else? Any other words?
Thinking outside the square, like, maybe talking about exercise, and she'll say to you, I can't do that because I've got a sore knee. It leads you down a pathway.
Great.
And you can, you might just have to go back with that goal, saying, well, what other ways can you do that?
Customising the goals based on the words and what the patient's experience has been. Fantastic. Anything else that's sitting there?
Information seeking.
Great.
If they're taking pamphlets, if they're, not just...
I want to know more.
Not just asking questions, but if they're in the waiting room and they're picking up bits of information.
That's me. I'm such a curious cat. I'm like, oh, what's that? Oh, look at that. But not necessarily everyone's like that, are they? They are all just sitting there staring mainly at the receptionist, finding out what's going on in the greater world of reception land. Yeah, it's a very captive audience, that area. All right, so let's move on. So trust and rapport, as I said, human connection is the best essential agreement to make sure that we're getting adherence from our patients. There's some fabulous data around how much patients actually can recall post your appointment. And do you want to know the stat? 20%. 20% of a recall on what information was just passed over to them. which is frightening, isn't it? And you think about those lifestyle discussions that we have in care planning, even though they're crucial to have, and we all need to do them because that's the prevention activity and minimising complications and them not getting other diseases. 5% of the population can do those 5 top helpful tips. 5%. So we're setting a really high bar of expectations up there as well, isn't it? That's why it's nice to have that style of questioning that's really genuine. I care about you and I want to hear from you what it is that you want for yourself moving forward as you age. What's important for you, not what's important for me and what the RACGP guidelines say. Yes? That's that quality of life piece coming in. This is the thing that's going to get them to put time, energy and effort into these activities. I also want to honour that I'm not the expert, they are. Because what we know about human behaviour is habits are the critical element that we can do for a client that means that they've got sustainable change for their life long term. They can do things in short bursts, granted, they're called extrinsic things, so you can go on a diet or you might do boot camp for a short amount of time and then you go, that's it, I'm done. You have a goalpost and then you stop doing it. The things that we know can stay, particularly with obesity strategies, the things that they can keep long term are those very things that they do every day. So we want to create those habits, those routines. Now, I don't know your routine and I don't know your routine, etc., but I need to give you this space and the opportunity to tell me that. So then when we're having new discussions about something new that you want to do, we can graft that new thing onto an existing part of your routine. Then you're going to get a nudge and a reminder and a cue. It's the best way to go. We also have this wonderful thing called communication skills. Now we understand each other because we're clinicians, so we have a common language. So we talk with each other in the same dialogue and same language. Clients don't necessarily understand our language. They might not understand PRN or things like that, but we kind of get caught up in our own language, don't we? So there's a lack of understanding. And one of the top complaints to AFRA is that patients didn't feel like they understood what either was prescribed to them or what advice was given to them and what their role in it was. So we need to make sure that we're communicating at a level that patient understands. Now there's a fabulous technology that we can use which is called Teachback, and all it is a communication style. So I might train you on how to do something and then you teach it back to me. Then I can understand whether you understood the information I just gave you. So that's a lovely way to do it. Looking at verbal and non-verbal information and speaking at a level of understanding. If I'm going to ask you a big question that you haven't thought about before, I need to offer you space to think about it. Don't assume that I didn't understand the question. Just give me some time and let me answer. Don't ask another question. All right, so here's what the body language looks like. And this was a study done by Amy Cuddy from Harvard University, and she is a little pocket rocket that just can spin you out all over the stage. She talks about studying human behaviour to get better performance out of teams. What's going on in a team meeting for those people in the room that are leaders? Are people invested in it as much as what you are, or are they sitting there daydreaming going, are they there? Are they showing up? So how can we tell? People that have high power poses are broad and expansive. And so she trains surgeons to stand in the lift like this as they're going up to perform a really technical piece of surgery, so that she sets up the right chemical reaction in their brain so they can think, listen, learn and problem solve and strategise. How cool is that? In terms of the reverse, can you think now of all the kids, my age kids group, who are looking constantly at their phones? They've got a decreased level of testosterone and an increased level of cortisol. Their stress response is right up there, so they can't think, listen, learn, problem solve and strategise. So I put that down to that's why my son doesn't hear me to wash the dishes every night. All right, so we have this wonderful formula, which is called motivational interviewing, and I think it gets and speaks to the heart of every interaction, no matter where we are in terms of our client contact. So we formulate a partnership with a client. So I may be an expert with some information that I can share with you, but I'm not an expert in your life, is what that means. So if you ask me a question or I offer you a few choices that you would like to explore, I can definitely use my expert hat there. Otherwise, I'm being what Rivka said earlier on, curious about you. I want to hear your routines, I want to hear your opinions, I want to hear your perceptions, I want to hear your past experiences to find out whether or not this is really something that you want. Autonomy is when we have choices around what it is that we're going to do. Now think about yourself. Is there only one diet out there? Is there only one way to exercise? No, there's plenty of ways, isn't there? So we need, as human beings, to be offered choice. If we're not offered choice and we're just told something, we're more likely to resist it and disengage. We also need to have a compassionate approach. So what that means is we all think as health professionals we have compassion and empathy. But it means we start using observational language rather than our thoughts, opinions and ideas about what's actually just happened for a client. So that means when I hear you say things like, I'm really proud that I was able to do blah, 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 I use the words back. So I hear you're proud, not I'm proud of you. Okay, we don't want to cheerlead people because when things don't go right, where do we go from there? They'll hide from us. Evoking with nice questioning style, open-ended questions. So I'm thinking about this toolkit. How are we going to ask clients to do it if they're standing in front of us with their opportunity in a treatment room? Who's got their little bow kit? Here it is, the home test kit. What's going to be your opening line to a client? You could do that. Feel like I just made an Instagram post. What is going to be your opener to discuss this with a client? How are you going to evoke discussion? Are you going to have it in the treatment room? On display? Any ideas?
We have it built into our academic health check.
Great. So you got it on your desk?
So it's sitting on my desk, I've got flipbooks, I've got posters.
Fantastic.
So it's built into the 45 plus health checks.
Excellent.
So we start the discussion.
Visual, which is why I'm doing that. Visual. We have 60% more chance of information getting absorbed by using visual tools. 60%. So the more times they see it, and sometimes it can be up to 6 times they need to see it before they go, oh, there it is. Yes? Have it all around the place, wherever you can possibly do it. How then would you open up the discussion? So you might have it in a chronic disease or a health check. What about if it's just in the treatment room? How might you open up the dialogue there and evoke interest into this?
Ask a question about it. Have you seen, do you know what this is?
Yeah,
Or
great, easy.
our posters that are up in the waiting room.
Easy breezy, light conversation. Have you seen this? Is this something you might be interested in? Yeah, rather than, here you go, I've got a present for you. Take it home and they'll go, oh, put that in the bin on the way out the door. Think about different opportunities, yeah? How can we approach this? So the visual tools, but evoking and stimulating interest is a really nice piece. Hi, resisting the writing reflex is around someone will say that they're actually undertaking something and you might not agree with it. So rather than arguing the case, we know that that just creates more resistance. So posing the question in a way that's about providing more health literacy around that space. Is it another area that you would like me to give you some more information? Is this the right time? Is a nicer way of handling it. Understanding their motivation. Now, how do we do that? Has anyone sort of thought about what sits behind motivation? Because I tell you what, if it was an injection, we'd all be saved, wouldn't we? Everyone goes, I'll do that when I've got motivation. Yes? I was really motivated then, but I'm not motivated now. Have you thought about motivation?
It's tapping into what's most important for that person.
Their values, isn't it? What do they value? And same with teams, when you're doing PDSA activities and trying to get team and leadership happening, it's around why are we all here? What's our common thing, our common purpose, our common mission that makes us all show up today? So for me, it's around longevity, because my grandma's 108. So I go, you know what, she's a pretty cool chick and she can get around, she's really astute and she's really funny and she knows what's going on in the world, and as long as I've got that kind of quality of life, I'd be pretty happy with that. If it was any worse than that, probably not so much. You know, she can still watch the footy, she can still do all those great things that she values in life. So for me, I think if I'm going to nominate time and energy effort to my health, it's got to be about what kind of quality of life later on down the track, okay? Understanding people's motives. Different ages will be motivated by ageing, so the older age groups will be more interested in that. The younger age groups more about that immediate short-term stuff. What's my life going to look like in 6 weeks, 3 months? More so than that longevity stuff. They don't care about what they look like when they're aging, because life's just good now. They want that immediate fix. Using open-ended questions, so the what's, the when's, the where's, the how's, yes, rather than do you, can you, should you. Affirming, so I hear that you've just said blah, blah, blah. Reflecting, summarising what they've said. And then when we get to ambivalence, I know that I should do this bowel test, but is always when you know there's a bit of ambivalence. But, that very word. Have we heard that a few times in our clinical space? I want to, but. How do we work through that but? It's nice to explore. So if you've got a short time-based consult, Michael Pantalon, you can write his name down. He has a fantastic little clip on it, and basically he unpacks how we can work through ambivalence in 7 minutes. And it's around just brainstorming in that moment. So we think of that short time-based consultation that we've got. We've only got a moment of opportunity to grab their attention and explore that and get them curious about it, plant seeds for future change. That's a really nice way to do it. So what we do is we brainstorm with them. So I hear that you're interested, you know that it'll be good for you, and I also hear that you're unsure because of these other reasons. Can we explore that? We've got X amount of time, nominate the length of time, it's really important to do, yes. And then say, tell me 3 good things that you like about what you're currently doing. What are the 3 things that are not so good about that? What about if you did this new change? What's 3 good things that would happen then? And what about 3 things that wouldn't be so good then? Just hear their ideas. Start to explore that, because there's going to be little nuggets there that they haven't thought about. They haven't sat down and unpacked this, and this is your opportunity to do that with them as a live brainstorming activity. And you'll get clarity around the patient's thoughts and perspectives around it. They'll get clarity around it as well, because they're saying it out loud. So it's a really important time and space to use those motivational interviewing skills. And once we have done that exercise, it's a really nice space to say, well, what's next? What's next for you? Rather than, great, you're ready to go to goal setting. No, settle down. Let's take it slowly. What's next? Okay? If they say, well, I think I could do, that's when you can go into goal setting and get down to the nitty-gritty with it. So I know that this is probably not what a lot of us do, but we need to start to think more about listening rather than trying to give a lot of information in one consultation. Can we space our consultations so we're drip feeding information and we're not bamboozling them? But we need to be setting it up that the client's doing most of the talking. So the questions that we ask need to make sure that it prompts the client to think and then answer with a response that we can listen to. It's going to drive a lot more insight into what's been holding them back, what their trends are, what their patterns are, what their routines are. The open-ended questions, we want to hear their opinions and their feelings on concepts, okay? What's their thoughts around this? Is there fear? Is that what's holding them back? So what questions? These are the ones that I use in care planning activities, and it's just broad and open. What's the best use of our time together today? What's concerning you with your health and well-being? What would you like to do about it? So this is really handing it over to the recipient, isn't it? If we're constantly prescribing things to clients, they become a passive recipient of our care. So when they try something and it didn't work, then you're to blame. Yes, I tried that and you said to do that and it didn't work. So we want to really flip it on its head. What would you like to do about it? What do you feel like you're doing well at the moment? Now this is an appreciative inquiry piece around talking about what people can do rather than what they can't do. What can you do is more empowering in a discussion. Then I might say there's that piece in connection if you're going to listen to that. What would you like to work on until we next see each other? So that's when we get down to the nitty-gritty of goal setting. Their motivator, we want to ask quality questions. Why they want what they want. What will it bring to their life that they currently don't have? How might they feel? What will they do as a consequence? All those sorts of things are where their motivations sit. The how questions. So we go from the what to the why and then to the how. Now, 8% of the people out in our communities are successful with habits by themselves. 8%. They are very good at being clear on their why statement. So they can go in their own brains from the what to the why to the how. But most of us do the what straight over to the how, and we forget this really important piece, which is the critical piece of the puzzle, which is the why piece. Why are we doing this? What are we going to gain from it? The how is about defining the details so that we can tick it off and see the progress. Our brain's really enthused by all those little endorphins when we succeed. Think about all the addictions that we have out there. They artificially stimulate the reward centre. So we need to do that when we're making goals, is have a mental tick off so that brain's really clear that we're making progress. So when I think about SMART goals, I don't necessarily think of them in that specific, measurable, realistic, attainable and time bound, because I just think it's just a framework that's a little bit too stuffy. I like to think of it as that cognitive planning. When I'm working with a client, I want them to visually picture their diary next week and when that's going to slot in and what they need to do and what steps they need to take. I want them to be picturing that. The more they can think it, see it and articulate it, the more likely they are to do it. So when you're thinking about SMART goals with a client, don't get too caught up into, have I answered all of these pieces? Think about it really in terms of what activity are they talking about? When are they going to do it? Is it days of the week, times of the day? Are they going to do it with someone else? Are they needing other team members to be involved? Accountability partners? What would you need? How often are you going to do it? And how will you remember? Crucial piece of the puzzle here, how are you going to remember to do it? It's all great and well to have an intent. So clients might craft really great goals with me, but then if they're not clear on what those goals are, they'll forget about it. So they'll go, yeah, I was really good for a week or two, then I forgot about you and I forgot about the goals, and then I saw you on the calendar and went, ugh, and then I got started again. So this is about filling in the gap, isn't it, and them being accountable to themselves. Do they need to put a reminder in their smartphone, on their calendar, a sticky note on the wall? What is going to help them? And how will you know that you've made progress? This is the same whether we're doing PDSAs in our team or working with clients. Same process. So when I think about SMART goals, I think of it more as a whole picture. I don't know where I've put my little clicker. Here it is. Handling reviews. It's really important, isn't it, that we've said to someone, yes, we're going to send you home and you're going to do X, Y, and Z. But it's also really nice to make sure that they understand that we're not looking for perfection. It's not good or bad or right and wrong. It's just about looking at what worked. So handling it so that they know when you come back, we're just going to have a chat about what you enjoyed, what didn't work so well. Yes, what do you need to adjust moving forward? Framing it up so that they know when they see you in the supermarket and they haven't done anything, that they don't go down another aisle, okay? How is it that we can make it that it's okay? So what I do with a client, freehand, because again, visual tools have a better retention rate. Something that's pre-printed doesn't necessarily grab their attention. Remember when I said before, physically get up and move? It's about giving you a brain jolt. And same with your clients. When they've been sitting there for a while with you, give them a brain jolt. So if they've done a SMART goal, I'll go, so sometimes we expect this from ourselves. We might think that we can go from here today, I'm walking 2 times a week, and next week I want to be working 3 days a week. And we think and expect this from ourselves. What's real is this. Until we work out the right way for us as humans, we might have, yes, the first week it went brilliant and then I got sick. Oh, that's right, I was walking. I need to get back onto it again, and I might last 3 or 4 weeks this time round, and then I go on holidays. And then as we learn how to tweak and adjust it so that eventually when we've got it right and it's part of our habit system, which can take anywhere between 6 months and 18 months. And why does it take that long? The longer you practice it and repetitiously do it, the more likely it is to get embedded in your brain. So if you have pauses, it might take longer. This is the stuff that I talk through with my clients so they are kinder on themselves. They will be more likely to be courageous and step outside their comfort zone when they know this is what I'm expecting from them. And when I talk about goals, I talk about it in terms of 1%. So I give them the expectation on what I'm talking about, because they are thinking a major overhaul. I'm talking about 1%. So between now and when we next catch up, what's 1% more that you'd like to tell me that you're giving a go? And they think, 1%, I could do that easy. What we're trying not to do is stimulate up that sympathetic nervous system again, aren't we? We need to make sure that they're on board with it so that they're more likely to do it. So 1% for SMART goals, normalise the process, that setbacks are going to be part of it, and be that accountability partner. What would you like to tell me that you gave a go or attempted, whatever words are appropriate for your consumers or your clientele? What did they learn? What needs to be tweaked and adjusted? Now, one of the things that I'd make sure is my goals are very clear on my care plan and right at the top, so that when they go to others and the GP, they can continue that same conversation with the client. The client's not having to explain themselves time and time again. It's very obvious what it is that they're working on. So people don't give them multiples of multiples.